Hello, everyone. My name is Joyce, and I'm presenting the con side of the debate that family members should be considered essential partners in acute care. I'd like to thank my opponent and friend, Shannon, for her thoughtful and passionate presentation. While I acknowledge the value family members can bring into acute care, this rebuttal challenges the proposition that they should be considered essential partners in all acute care settings. I argue that requiring family involvement introduces practical, ethical, and clinical challenges that can compromise the safety, fairness, and effectiveness of care. Rebuttal number one. Let's begin with one of the core claims Shannon made, that family presence reduces workload for staff. While this sounds promising in theory, the reality in acute care settings tells a different story. These environments are already strained by chronic nursing shortages, high patient acuity, and competing priorities that is well documented by the BC Nurses Union. Family members, even well meaning ones, are not trained professionals. Will we delegate medication administration or drawing blood samples from an art line to them? Most would agree that we wouldn't or shouldn't. Even tasks like feeding or helping with hygiene assume ideal conditions, including proper education, patient assessment, stable staffing, and role clarity. But those conditions are rarely guaranteed in real life. I've seen more than once where family members begin feeding patients who were lying completely flat. Situations like these require nurses to step in, spending valuable time correcting misunderstandings, providing guidance, and managing safety concerns. Rather than decreasing workload, family involvement in these cases often ends up increasing it. What looks like support on paper often turns into supervision, coaching, and managing risks at the bedside. Rebuttal number two. Shannon argued that family members are essential to patient safety, but the evidence doesn't support consistent or safe implementation. Guaza and Masiska found that many hospitals lack formal policies or clear role definitions for family involvement. Without these structures, communication breaks down and care becomes fragmented. Their review also noted wide variability in how patient and family centered care is implemented, making the idea of family members as essential partners impractical across most settings. More importantly, this debate isn't just about allowing families to be present, it's about making them essential partners in acute care. That's a much bigger ask, and it's not fair to assume every patient has a supportive, available, and or capable family member. As nurses, we're responsible for making sure care is fair and tailored to each person. The British Columbia College of Nurses and Midwives reminds us to reflect on our values and make equitable decisions. Calling family members essential partners could unintentionally overlook patients who don't have that kind of support, which raises concerns about fairness and truly individualized care. Rebuttal number three. Shannon highlighted emotional support as a key benefit of family involvement, and I fully support that it's important. But emotional support doesn't automatically translate to measurable clinical improvements. For example, Healthcare Excellence Canada reports that family presence may improve things like hand hygiene or medication self management, but these are process measures. When it comes to clinical outcomes such as infection control, wound healing, or intubation success, the evidence remains limited. Shannon also cited lower readmission rates and fewer discharge delays, but those don't necessarily reflect actual physiological recovery. A patient might feel more at ease, and there may be short term benefits like slightly lowered blood pressure, improved glucose control, or reduced pain, as reported by De Castra et al. But these effects may be temporary. If the patient's underlying conditions, such as cancer or diabetes, is still progressing, emotional presence hasn't changed the clinical course. This falls into the appeal to emotion fallacy. While emotional benefits are real, they don't justify calling families as essential partners in a rebuttal number four. Lastly, many of Shannon's examples come from the COVID 19 pandemic. While those were powerful and emotional stories, they represent extraordinary circumstances and not standard practice. Studies like Moss et al. Showed that 90% of families struggled with separation during visitor restrictions. These findings reflect a moment of crisis where fear, loneliness, and grief were on the extreme end. But using pandemic specific data to support a permanent change in care model risks a post hoc fallacy. That is, just because harm occurred in a crisis doesn't mean the same result will happen in routine everyday care. Policies and emotions from a crisis shouldn't be the model we use to shape long term systems, especially in complex areas like acute care. In conclusion, while family involvement can be helpful in specific situations, declaring them essential partners across all acute care settings raises serious safety, equity, and logistical concerns. I have shown that their involvement can increase the burden on nurses rather than relieve it, lack consistent policy or role clarity, provide emotional value without improving clinical outcomes, and are based on crisis era data that may not apply to typical care environments. True partnership requires more than presence. It requires preparation, structure, and system or policy readiness. Until those supports are universally available, mandating family involvement as essential is not safe, not fair, and not feasible. Thank you very much.